Very exciting program here. We will be recording. I hope it's okay with everyone. Okay, so I'm happy to invite you all to the Prevention of Perinatal Mental Health Disorders Special Interest Group of the Marseille Society. And the topic today that we're going to discuss is how do we increase access to prevention for perinatal mood and anxiety disorders. And we have four very exciting talks today, two from Israel and two from the United States. Each presenter will present between 5 to 8 minutes. By 8 minutes, we're going to stop you, so try to stay on time. After we finish all the presentations, we will have around half hour, 20 minutes for questions, discussions. That's also a good time, you could introduce yourself, maybe even say a little bit what you're doing and how it's connected. Each one could choose whatever they want. We'll have that time for this, introduction and discussion also. Yeah, so these salons are very exciting, and I invite you to, if you want to present yourself, or on future salons or participate, we'll be very happy to do so. So I am Rina Bina from the School of Social Work at Bar-Ilan University, and I'm going to be the moderator today. So without ado, let's get started. Our first speaker today will be Dr. Vered Bar. She's the head of the Chava Center of Reproductive Psychiatry Unit at the Sheba Medical Center in Israel. And she will be presenting about prevention in reproductive psychiatry at the Chava Center. So please, Vered.
Thank you. Can I share screen? For some reason, I'm getting all the admission requests.
Yeah, I made all of the presenters co-hosts that you're able to share. Ignore the admitters part. I will let them in for you guys.
Okay. Okay, so can you see my screen? Hold on. Loli Kanes, toda. Okay.
Yes, though it's not, it's the full screen of it. It's okay. Just
okay. So I want to say thank you to Mimi that's not here, and of course Emma and Rina and all the distinguished guests here, and my co-speakers Lorraine, Elizabeth, and Maya, and all of you for the opportunity to meet and discuss prevention of perinatal mental health disorders. I hope to learn and improve our strategies, since the best medicine, in my eyes at least, is preventive medicine. Good morning to those of you in the United States, and good night in Australia. I wish I could say good evening here in Israel. Today we mark 4 months since the horrifying attack on Israel. October 7th, hundreds of Israeli civilians were raped, mutilated, beheaded, killed, and kidnapped to Gaza. This includes babies, children, women, including pregnant women, men, and elderly. 136 Israelis are still held as hostages in Gaza. Since October 7th, the brutal war is going on in Gaza. The north part of Israel is bombarded daily. Hundreds of thousands of civilians are still evacuated from their homes. Perinatal mental health is always extremely important. Since perinatal mental health is the most prevalent perinatal complications, it has grave outcomes for babies, families, and societies, and it's the leading cause for maternal death in developed countries. And most important, it's treatable and preventable. Prevention of perinatal mental health disorders is even more important in Israel today, since during COVID-19, we know that by research done by Rina Bina herself, mental health issues, perinatal mental health issues raised by 40%. I expect a steeper rise right now. This calls for urgent prevention efforts in Israel today. I want to present you with the Chava Center model of care with an emphasis on prevention. Chava Center is located in Sheba Medical Center, the biggest medical center in Israel. In Hebrew, the word hospital means home of the sick. The head of Sheba, Professor Christ, changed the name for the city of health, as you can see here. This means we not only take care of those who arrive sick, but actively initiate health promotion and prevention. Sheba consists of a general hospital, women's hospital, children's hospital, oncological hospital, virtual hospital, and rehabilitation hospital, including psychiatry. Our ability to collaborate to address all health issues in one place gives women and families the best medical treatment. We are in daily contact with the maternity wards, high-risk wards, children's wards, and more to better address women's need. In my perception, this is what makes Sheba top 10. Prevention can be divided.
Jared, 1 second. You're not on a presentation thing.
Oh,
It's not
okay.
moving.
Let's go back. And now?
1 second. Yeah, now you are. Very
So
good.
you missed the previous slides. I'll send the
You're
slide.
good.
Sorry, with communication management. You're fine.
What?
Those plans that were
I didn't hear whoever was talking. Okay, thank you, Lena. Okay, where was I? Prevention can be divided into primary, secondary, and tertiary. Primary prevention deals with the general population. Maya will soon elaborate about our webinar. We also promote awareness in the general population by social media, and we even had a TV show filmed in our Mother Baby Day unit, which really raised awareness to perinatal mental health issues. Secondary prevention has to do with early detection. We teach gynecologists, pediatricians, nurses, and all medical personnel involved in treating perinatal women how to detect perinatal mental health disorders early on and who to refer to and where to refer to. Tertiary prevention has to do with early and precise interventions to minimize damage. This is best done by specialized treatment centers treating all aspects of the disorder at the same time and place. This is our model of care in Sheba Medical Center, Chava Center. Whoop, now it's not working again. Okay. So this is our model of care, a comprehensive therapeutic center for women experiencing emotional changes across the reproductive cycle, giving preference to treatment at home, thus minimizing the separation of the women from the babies, the family, and the community, with the aim of reducing morbidity and improving the prognosis of the women, the baby, and families, and the community. We receive around 100 new referrals a month, meeting over 1,000 new referrals a year. We also do consultations in the women's hospital. Thus, we can see women. I've already seen women in right after birth or even before birth in the maternity ward. Unfortunately, most of the referrals are postpartum women, about a quarter post-stillbirth, around 20% are pregnant women, and only 8% come for a preconception consult. I hope one day most of the circle will be light blue. All women go through a psychiatric intake, at the end of which a treatment plan is decided with the woman and her family according to the level of intensity she's needed. Chava Center includes an ambulatory clinic, a mother-baby day unit, dyadic hospitalization, meaning women are hospitalized in a psychiatric women's ward, and the baby is brought daily by the family for dyadic intervention, and a virtual perinatal ward or home online hospitalization, if you want, which Maya leads, meaning women receive the intensity of care of psychiatric ward in the comfort of their home, without separation from their family and community. By the end of this year, we are opening a full mother-baby unit. Women can begin treatment at any level of intensity and change treatment plans according to the level of care needed. This prevents relapses that often occur upon changes in treatment settings. For example, around a third of women discharged from mother-baby units around the world are rehospitalized in 6 months. In our dyadic hospitalization, only 1%. Since the day after discharge, they are accepted in the next level of care. Treatment in Chava Center includes psychiatric, psychological, social, dyadic, and family interventions, aiming to deal with all aspects of perinatal mental health issues, thus minimizing the collateral damage. in perinatal mental health issues, we have the privilege of preventing sickness or disorders in women, but also treating them promptly and shortening the period of time they suffer is a real prevention for the babies and the families, saving marriages, saving perinatal disorders in the partners. So that's our model here. Thank you for
Thank you very
listening.
much. Thank you very much, Vered. Just on time. Thank you for presenting us with the model of care that you give and the prevention things that you do. Thank you very much. Our next speaker is Dr. Maya Sheffer, which is she is a senior psychiatrist, the head of the virtual ward, an online perinatal psychiatric home hospitalization service in the Chava Center for Reproductive Psychiatry unit at Sheba Medical Center in Israel. Together with Dr. Bar, she developed the emotional and mental preparation for childbirth and the transition to parenthood webinar, which we will be presenting right now. Thank you, Maya.
Thanks. Do you all hear me? And do you see the slides spread on all over the screen?
Yeah.
Great. So as Vered already mentioned, I'll now be presenting one of the preventative measures developed in our center, which is our prenatal mental and emotional preparation for childbirth and the transition to parenthood webinar. And as Vered mentioned, the Chava Center is part of the Sheba Medical Center, and one of the main advantages of working in a big hospital campus like Sheba is our collaborations as perinatal psychiatrists with our peers in the maternity hospital. Several hospitals in Israel, including ours, offer free prenatal courses. And Sheba has quite the variety of prenatal classes, as you can see here, classes for parents of twins, for single mothers, for ultra-Orthodox community. There's a short course and an extended course and a special course for women planning to give birth in cesarean. And during COVID-19, all prenatal courses, including the virtual visit to the maternity ward, went online. And this was a time of great opportunity for us to integrate a new prenatal course to the existing variety, the one we've seen as needed and dreamt upon giving, which is our emotional and mental preparation for childbirth and parenthood course. Most prenatal courses deal with the obstetric aspects of childbirth. Others include some information about the first days after delivery, but they usually focus on the physical care of the newborn without addressing the psychological impact of the transition to parenthood on the parents themselves, and parents often feel underprepared. And just like this John Lennon title, day after day, we encounter women after birth who are asking us, how come nobody told me? So we decided we'd tell them. The webinar is based on our successful experience with accompanying high-risk patients and good transition to parenthood, and what we know from the literature about what new parents need, addressing possible risk factors in postpartum mental illness, and what's been useful regarding prevention before. Before I delve into the specifics of the webinar, I want to discuss some of the principles it was based on. So the whole webinar is a psychoeducational based. As we say, knowledge is power. And one of the main take-home messages participants are supposed to come out of the webinar with is the understanding of how important is mental health of moms and parents to the health of the whole family, and understanding that the perinatal period is a period of great vulnerability for mental health. As every preventative measure, we aim to address different risk factors, for example, increasing support where possible, talking about the power of the tribe, understanding that we were never meant to do it alone. We also invite spouses or main caregivers of the women who participate as well, as it conveys both the message that their mental health is also important, and that we're not supposed to just be talking to the moms. It's an issue for the whole family and the whole of society. Also, from a biological perspective of the theory that all known risk factors are contributing to, if you will, a final common pathway of increasing stress and cortisol, and its effects on immunology in the brain, we talk about avoiding stress where it's possible as a major principle. We know birth trauma and experiences postpartum are extremely subjective, and many times they have to do with broken or unmet expectations. You can see here on the slide published work from 2022 suggesting interventions to prevent suicidal thoughts and behavior postpartum, And they suggest it should include helping women manage their expectations for pregnancy and postpartum. And so this is some of what we're trying to do in giving the webinar, adjusting expectations postpartum to be more realistic. Another principle is working towards increasing feelings of safety during childbirth. This again is based on the important biological role of oxytocin to enable birth and helping avoiding a cycle of fear and tension and pain as possible as we can that could induce adrenaline secretion and hinder the birthing process. One of the main principles we think is important to discuss with new parents is the whole perinatal field is characterized by such circumstances of uncertainty and loss of control. So first, we think it's important to understand and accept, and we try helping parents adapt to a less rigid, more flexible and curious mental stance to help them navigate better those circumstances. The last principle is that we open the door for those with current and future needs to access us. They meet these two not so intimidating and even nice psychiatrists, and it facilitates approaching us, decreasing the stigma of accessing mental health care. It was shown in several researches that the most high-risk population are many times reluctant to access preventative care during pregnancy. And so by knowing us and the Chava Center, they're given information about somewhere that they can approach if something is not okay postpartum. Most prevention programs developed and published in the literature require several visits and are mainly addressing high-risk populations. Our webinar is open free of charge to the general population and is a single 1 to 1.5 hours meeting. We see many advantages in this form of prevention as the online format allows women from all over the country to participate, and partners or main caregivers are addressed too. As I explained, it may reduce the stigma and some barriers for help seeking later on if needed. We don't record our webinars now to allow participants to feel safe asking us anything, but if recorded, this webinar can be given as a toolkit to every birthing parents anywhere. High-risk populations, such as pregnant women being treated in our clinic, are also invited, but also receive another meeting with a midwife and another meeting with the treating psychiatrist to address individualized need on top of the webinar. Up until now, in almost 3 years of running, the webinar was very well received by both colleagues and pregnant couples with high satisfaction. They thanked us, and some have called it a must. Our vision is that every couple in the state of Israel before birth to have it as an integrated part of their pregnancy care package. We intend to start investigating the effectiveness of this tool on postpartum depression and postpartum PTSD prevention and the well-being of new parents. So let's dive into the content of the webinar. So the webinar has 3 parts: childbirth, the transition to parenthood, and a practical toolbox for maintaining good mental health postpartum. When we talk about childbirth, we talk about managing expectations. We talk about how common fear of childbirth is and how prevalent are states characterized by feeling loss of control, not just in the delivery room, but across all of the perinatal field. We emphasize the importance of not coming with a rigid goal or mindset, instead adapting as much flexibility as possible. We advise not to think birth plan, and as no planning is really possible, but thinking about birth preferences. In order for women to feel safe during labor, we advise openly discussing their expectations with their partners and their midwives. We tell them about special midwifery services for trauma-informed care available. We then go on and talk about, oh, sorry, that was supposed to be the slide of me talking before. We then go on to talk about the minutes and weeks after delivery. We talk about expectations about meeting the baby from the first time. We give psychoeducation as to normal crying behavior in newborns. This is an element taken from Elizabeth, which will, I think, talk after me, and Catherine Wong's PrEP protocol. We talk about taking time to heal. We talk about the importance of the tribe, what to expect during baby blues, and the very common scary intrusive thoughts parents may have. Here too, we try to instill a less rigid and perfectionist, more rounded expectation about parenthood. We talk about how it's inevitable to make mistakes as a parent and how important repair is. We talk about the effect of the couple's on the couple's relationship and advise working together, keeping the foundations of the family, and about the dynamics that may happen in the extended family and how to address those. We then very elaborately talk about breastfeeding as a journey that many times encounters difficulties and emphasize the importance of preserving mental health on top of every other consideration. We also talk about the possibility of partial breastfeeding as beneficial as well.
Maya, you have to finish, so a half a minute and to be done.
So, okay. So then we go on to the toolbox. This is something we call the Khamsa law. Khamsa is symbol both in Arab cultures and in Jewish culture of something that's keeping you. I didn't have a good mnemonic in Hebrew, and this is why it's called the Khamsa law. But I understand in the States it's called nests. But we basically speak about the importance of sleep, of support, of time for yourself, of engaging in joyful activities for the mother, of doing a physical activity, and the importance of nutrition. Then we finish the finale of our webinar is talking about postpartum depression, giving possible red signs that they might see, and we give the contact information of our centers in case of need.
Thank you very
Almost.
much. Thank you very much. Very inspiring and interesting. Thank you so much. Our next speaker is Dr. Elizabeth Werner. She holds a dual faculty appointment in the Department of Obstetrics and Gynecology and Psychiatry at Columbia University Irving Medical Center, where she serves as the Director of Clinical Intervention Research in the Perinatal Pathways Lab. She's also the Associate Director of Women's Mental Health at OBGYN, a clinical service providing perinatal mental health care, and the Associate Director of the Center for the Transition to Parenthood, Two-Generation Impact. Dr. Werner is a co-developer of PrEP, a clinical intervention that aims to prevent postpartum depression, and the director of the PrEP training and certification program. She will present to us a brief interventions as a way to increase access to prevention. Please go.
Nice to see everyone. Let's see if I can share my screen successfully. Oh, sorry. I think I didn't do that right. Hold on one second. Give me 1 second. I think I clicked the wrong thing. Here we go. I think we can see that, and then I can start the slideshow. Let's see. Are we all seeing the same thing now? Yes, fantastic. So happy to be here. And Maya, I feel like our work really speaks to each other. And there's a lot of really great overlap. So it's really nice to hear about your work and see you here. I'm thinking a lot about ways to increase access to perinatal mental health care through brief psychotherapeutic interventions. I'll be speaking specifically about an intervention that I developed along with my colleague, Catherine Monk, called PrEP. But first, I thought it might be nice just to talk a little bit about sort of barriers to mental health care during the perinatal period. First, in the United States, which of course I'm most familiar with from my own experiences, is having difficulty getting patients into care. But I think a lot of them are universal. And then the next slide, I'll talk a little bit more about, around the world, some challenges that have been cited in the literature. So in the US, because we don't have any kind of socialized medicine program, cost of mental health care or having a provider that has the training and also matches your insurance can be hugely challenging and really hinder people to getting care. Resources in general, in terms of finding mental health providers that even have the training for maternal mental health care is very low. And there are areas in the United States where there's just no one who was even remotely trained to provide this kind of care. The amount of time that it takes, oftentimes people are busy with other children, their other OB appointments, so it can be really difficult for them to find time to get the mental health care. Of course, stigma, and I think that's present in many cultures. There's a lot of shame endorsing mental health symptoms in general, but specifically in the context of childbearing. And then there could be a disinclination to take medication while pregnant or breastfeeding. And then just briefly to go over some global barriers. Again, resources, just like in the US, there's lots of places around the world where there's people without training in perinatal mental health care, lack of provider knowledge. There is a lack of screening. There is, sorry, do I need to do that admit? I don't know if I do. There are low referral rates. So even people who are screening, they may test positive for a PMAD, but then they're not actually getting referred. That was a study in the UK. And then there are, of course, logistical barriers caused by poverty, difficulty with transportation. So there's a lot of barriers to care. And let's see if I can get this to extend. There we go. this is just a slide of some things available to people in the US that I think have really helped improve access to care. Everyone or most people know about McPAP for Moms and Nancy Byatt's work if you've been to any of the Marseille conferences or other conferences on this topic. She talks a lot about their program where OBs are provided with psychiatric consultation, which can be really helpful if there are concerns during a pregnancy. They also help people find referral support groups. Project Teach is something available in the US, which is helpful in that way. Postpartum Support International, I'm sure we're all familiar with, has been wonderful resource for online groups now and a confidential hotline. The US Health and Human Services Department now has a hotline for people to call during the perinatal period called the Maternal Mental Health Hotline, which has been really accessed by a lot of patients. And it just provides people, especially in these sort of provider deserts in the US, access to someone to talk to about their mental health during this period. And then shout out to Lauren, who you'll hear from in a little bit. The National Curriculum for Reproductive Psychiatry is really an amazing program that is that it can be self-guided, but provides information about reproductive psychiatry to mental health professionals. And I know there's been a real emphasis on providing this curriculum to residents and to medical students. So it's really becoming more of education. So it's not sort of this super subspecialty that nobody has, but something that everyone is trained in so that there's more well-trained clinicians, because everybody's born. And so it seems to me that everyone should be, who's providing mental health care, should get this training. So shout out to Lauren and her colleagues who have really championed this national curriculum. I'm going to talk quickly just about our intervention. Again, it's called PrEP, which stands for Practical Resources for Effective Postpartum Parenting. It's a brief intervention. It focuses on the parent-infant dyad, and we were really interested in the research that showed that there is a relationship between parental mood postpartum, specifically depression and anxiety symptoms, and infant behavior. So increased infant crying, or infants that are considered to have more challenging temperament or more difficult sleep patterns. And so we wanted to provide people with tools to help them feel more efficacious as parents. We also wanted to provide them with psychoeducation. And Maya, that is really what people don't know, what no one tells anybody anything, right? What to expect. So how do we present people with information about what to expect? What's going to happen with your hormones postpartum? What are the baby blues? What's the difference between that and postpartum depression? What can we really expect from babies in terms of the amount they're going to cry, the amount they're going to sleep? Setting those expectations is hugely important. So it's a kind of combination of teaching people parenting skills as well as providing people with psychoeducation. We have designed this so it can be provided by a variety of clinicians, and we've trained lots of people to provide it in different settings. We try to use language that reduces stigma. So we call our therapists coaches, and we're really presenting this as an intervention that's focusing on developing parenting skills, reducing stress and things like that, which can be more acceptable to some people who may be resistant to more traditional mental health care. It's proven to be low cost and efficient. We can offer it via telehealth. It also has been offered as part of regular obstetric care. So you go in for your 28-week ultrasound and you have your PrEP session right after. You deliver your baby and someone comes to you the day after in the hospital and provides you with the newborn touch point session. We've designed it to serve those who are at risk for postpartum depression. So in our clinical trials, it's people who have high levels of stress, a history or current depressive symptoms, those people who are experiencing poverty. And then we like to think about this, and I'm sure, Maya, you feel the same way about the work that you're doing, is that PrEP can be useful for everyone, but it's not enough for everyone. And so for those people who it may not be enough for, it's a wonderful tool for screening, and it can provide screening for the development of more serious mental health issues. And that earlier detection can often lead to earlier treatment, and those symptoms often don't become as pronounced, people are getting earlier access to treatment through being enrolled in a program like this. And then the last bit is just a bit about, I don't know how many minutes I have left, but a bit about kind of the major touchstones of the protocol. So there are 3 sessions, which can be delivered in person or over Zoom that are about 45 minutes. And then we have 2 check-in phone calls. And each one of those is covering these main areas: assessment and psychodynamic interviewing. We're wanting to promote mindfulness as well as self-reflection skills, setting some parenting intentions based on their own upbringing and experiences. We're really focused on building the therapeutic alliance. When you have not that much time, you need to really make maximum impact. So we want to really help patients feel connected to their provider and trusting of their provider. And then we want to make sure we're gathering really important information about their lives. So each of the skills we introduce are introduced to them in a way that's tailored to who they are, who's living with them, and what their experience is.
Elizabeth, 30 seconds.
Okay, no problem. Again, as I said, we talk about psychoeducation, and we provide people with psychoeducation so they can limit negative self-attributions. You're not feeling a little more emotional after you give birth because you weren't ready to ever be a mother, but perhaps because your hormones have had this huge shift. We want to give people ideas of what to expect from the infant, and then we teach them some caregiving techniques: how to accentuate day and night cues, how to use swaddling to increase sleep and reduce crying, and how to use focal feed later on to help babies sleep longer at night. And I believe that's everything for me. So thanks a lot for listening, and great to connect with everybody.
Thank you so much, Elizabeth. Very interesting and good to hear about. I read about it, but to hear it from you is like much more exciting. So thank you. Our last speaker for today is Dr. Lauren Osborne. She's an associate professor of OBGYN and psychiatry and serves as the vice chair of the clinical research in the Department of Obstetrics and Gynecology at Weill Cornell Medicine. She is an expert on the diagnosis and treatment of mood and anxiety disorders during pregnancy, the postpartum, the premenstrual period, and premenopause. She will be presenting to us about training more providers as part of a reproductive psychiatry curriculum as a way to increase access to prevention. Please, Lauren.
Hi, everybody. It's great to see everybody, including old friends that I last saw a year ago in Israel, and everyone else that I haven't met. Great to meet you. My presentation will be a little different from the others because I'm not presenting about a clinical intervention, but rather presenting about an educational program. All right. Are we all seeing my slides? Okay. So I don't have any disclosures. I always like to say that I'm probably going to use the term female women and mothers. I know not all birthing individuals identify with this label, but I find myself tripping over it if I do anything else. So why are we talking about education in perinatal psychiatry? So this is one of my favorite slides. This is from a paper that was done a couple of years ago showing the perinatal depression treatment cascade, right? So this is a US sample, but if you look at all the women who have depression, antenatal or postpartum, we're doing a shockingly bad job treating them, right? We're not diagnosing, we're not treating adequately, and only 3 to 6% of people are actually treated to remission. So we do a really bad job with this, and we do a bad job for so many reasons. A lot of it is issues of access to care. A lot of it is issues of not having the right interventions, but also a lot of it is that our providers just aren't trained to recognize these disorders and to get people to the care that they need. Here in the US, we have a problem with the labor force, and I'm talking specifically about physician care now, simply because I am a physician. That is not to say that other types of specialties in perinatal mental health care aren't important. They of course are, but the physician workforce is really dire in terms of people who have training in reproductive psychiatry. So we've got about 25,000 psychiatrists in the US. We got about 20,000 obstetricians, but we only have about 500 people who are appropriately trained in reproductive psychiatry. And so when you train to be a psychiatrist in the United States, you have all of these requirements. They include 2 months of child and adolescent psychiatry, in which you have to treat both male and female children. But in adult psychiatry, there's no such requirement. You could get through all of adult psychiatry never treating a woman if you really wanted to, I suppose. You have to have geriatric psychiatry, addiction, consult liaison, forensics, emergency psychiatry, but there's no requirement for reproductive psychiatry at all. And in fact, the didactic instruction is supposed to be coordinated with concurrent clinical experiences. So people who are training, for example, in a Veterans Administration hospital might not have much access to a perinatal population. In obstetrics, it's not much better. This is the guide for graduate medical education in obstetrics and gynecology. There's one mention of perinatal mental health, and it appears in a section on postpartum complications, and it sort of gives a vague notion that people should be able to diagnose and manage postpartum depression, anxiety, and suicidal ideation. So we're not educating our trainees at all to become prepared to treat this population. And yet ACOG just put out these amazing new guidelines that said all obstetricians should know how to evaluate, diagnose, and treat perinatal mood and anxiety disorders, but we're not educating people to be ready to do that. So what are the barriers to teaching more? Primarily, the barriers are lack of time. There are all of these requirements in the US. I'm not sure how it is in other places, but in the US, tons of requirements to fulfill the Accreditation Council, and there's no time beyond that to teach anything else. And then a lot of places said, I don't have anybody qualified to teach this. We asked residency directors, well, do you want to teach it? Like if you didn't have those barriers, would you teach it? And almost everybody said overwhelmingly, yes. This red bar is the people who really thought that education in reproductive psychiatry was just as important as education in other fields. And the purple bar is, well, maybe it's not quite as important as, let's say, schizophrenia, but it's still really important. So we have, 80, almost 90% of people saying, yeah, this is something that should be taught, and yet they're not doing it. So we decided a number of years ago that my group started meeting about this in 2013, I think, and we finally launched our curriculum for the first time in 2019, and it's an online curriculum that is designed to be used in your local setting. It's not something that's designed to be done on a computer, because when we talked to residency programs, they said, no, we want to teach our residents here. We just don't have the capacity to do that. So we created a curriculum that would allow any mental health professional, whether they're trained in reproductive psychiatry or not, to teach a group of residents using our materials. So we made two versions of each module in the curriculum, one for the trainees and one for the facilitator. And the facilitator one has all the answers in it and has explanations so that the person teaching can learn for themselves and be better prepared the next time. So we have 13 different modules available on our website. They're all available for free. Anybody can use them. And although it was designed to be used in psychiatry residency curriculum, we very quickly discovered that a lot of other people wanted to access it. And so some people just go through the curriculum on their own. And we've also prepared a number of offshoot things, which I'll tell you a little bit about. So does our curriculum help? So these are the data from the first administration of our pilot program of the curriculum. And what you see on my left, I guess it's your left too, is the content test, where we gave them a set of 29 questions governing the content of the curriculum. And you can see that from before the curriculum to after the curriculum, the scores went up by quite a lot. And I should emphasize that not every program that piloted the curriculum did the whole curriculum. So there are these 13 modules. Some of them did only a few, and yet the scores went up all together. So that to me says that they're learning even more than we can see here, because they didn't even do the whole curriculum. And then on the right, we have their preparedness. So the question was, do you feel prepared to treat women with mental illness in pregnancy and postpartum and around other reproductive transitions? And you can see the light gray bars are before they did the curriculum. And you can see almost everybody felt unprepared or a little bit prepared, and only a few people felt somewhat or well prepared. Whereas after doing the curriculum, almost everybody felt either somewhat or well prepared. So the curriculum is working in terms of improving their knowledge, and it's working in terms of improving their confidence that they're able to do this. So as I said, a lot of people have been interested in using this curriculum in other ways than the ways in which it was designed. And so we've been making spin-offs from that to try to better address those other audiences. So we have in the works right now what we call NCRP XOB, which is essentially taking our modules and adapting them for an obstetric audience. All of our modules are lengthy case-based materials that you would use in a psychiatry 1-hour didactic. They're quite wordy. They get into the details of the case. They're really meant for people with a mental health background. Obstetricians don't want to hear that. They want bullet points. They want something fast, something quick. So we've taken all of our materials and adapted them into that kind of bullet point format for obstetricians. And this year we're piloting that curriculum in a bunch of obstetric programs, and we hope to have some data from that soon and be able to post those on our website soon as well. We've also now run 2 years in a row what we're calling NCRP Advanced, which is really more NCRP Intensive, which is a 3-day CME event where you can come and learn the whole curriculum with the whole NCRP team there teaching you over the course of 3 days. It's a very intense 3 days. You know, we start at 8 in the morning, we go till 6:30. There are no breaks. You know, you just have to, you know, it's like being on a hospital rotation. But it's been very, very popular. This year, with the second year we did it, we sold out in a matter of weeks and had to stop enrollment there, because one of the things that's a hallmark of the NCRP is that this is an interactive curriculum. It is not somebody giving a lecture at people, so we keep the groups relatively small. But we'll be running that as a yearly program. How many?
30 seconds.
30 seconds. Okay. We also published a textbook. We also have a series where we are teaching fellows in consult liaison and women's mental health across the US. These are some data from the first year of our fellow series. We now have about 50 fellows enrolled on a yearly basis. Again, this is just the pre-post of the content test. They're learning something. And that's the end. This is the website for the NCRP and a little QR code if any of you prefer that to a URL, and happy to answer any questions.
Thank you very much for your very interesting presentation. Okay, so we have 15 minutes now for questions, discussion, anything that people want to raise. You could ask one of the presenters a question. You could present how your work is the same. You took from it, you're learning from this, things that you're doing, anything that you would like to raise for discussion. Please go.
I have a question for Dr. Osborne and Werner. I was wondering if you are, and I'm Jill Zekwe, I'm a family doctor, and I have my master's in counseling psychology, and I have a practice just in women's mental health. And I do the Motherhood Survival Manual on Instagram. I was wondering if you were doing any training for family physician residents, because they do quite a bit of obstetrics. They have 2 months of required psychiatry training in their residency. And it's something I think they'd be really interested in. They take care of the mother and the child. And I was wondering if I reached out to some family practice residencies, if that would be something that'd be appropriate, that you'd be interested in working with or doing your program.
Absolutely. So we, in our first piloting of the curriculum for psychiatry residency programs, we actually had one family practice residency program piloted, and we collected data on them separately. Understandably, their knowledge was a little lower at the outset, but they also gained just as much as the psychiatry residents did. So I think it's very much could be applicable in family practice. I think the one issue might be that there may be less likely to have a local facilitator who could present the material, because there may be less likely to have mental health knowledgeable facilitators in their program. So they might have to think about that. You know, the materials are aimed at either obstetrics folks or psychiatry folks, so they'd have to think about which one fit their program best. But the CME event that we do, you know, we're looking at this as a kind of it can also be a train the trainer event. And our most recent one, we had a lot of people from family practice there. We had a lot of people who were certified nurse midwives and psychiatric nurse practitioners. We had a big group of those. And a lot of them were coming and saying, I want to learn this so that I can go back and teach it in my place. So that would be a really appropriate way for facilitators in a family practice setting to come learn the material and then go back and teach it.
Yeah, perfect. Thank you.
Mm-hmm.
I'm just taking off an airplane, so if I could jump ahead, and this is Harvey Clark, pediatrician, and we have a number of studies underway now using SNU with different populations, babies withdrawing from opiates. We're studying those parents, looking at mental health issues as well as normally developing children, and we're just developing a study in a Medicaid population in a large Midwest state where we'll be using SNU with women with a prior history of significant mental illness and substance use, Thousands of people have access to SNU now for free in the United States, and we're looking for more researchers who are interested, especially in working with high-risk populations, if it's prior OCD, bipolar disease, schizophrenia. What we've shown so far, we've measured 600 million hours of infant sleep, showing that SNU adds an hour or more to the baby's sleep. It calms about 50% of infant cry episodes. Usually in just a minute or two. We've measured about 50 million cry episodes with the bed. So we're looking to see about deploying this as a 24-hour support for the first 6 months of the baby's life, in addition to all of the very important psychodynamic and insightful and meditative practices that we discussed earlier. Thank you.
Thank you. Any other questions? Yeah.
I don't have a question, but just a comment. Thank you, everyone, and Dr. Osborne, especially for bringing the reproductive psychiatry curriculum. I'm from Hershey Medical Center, director of Women's Mental Health Program. And actually, I would share that it was always challenging to bring in the curriculum. And I started with kind of bringing the Project Echo so that at least I can bring about more and more awareness about mental health concerns to as many people who are interested in women's mental health or who take care of women. So that's how I started the perinatal mental health. And finally, of course, went in for grand rounds to different departments locally, but finally launched the reproductive psychiatry curriculum, both for our psychiatry trainees as well as OBGYN. And as Jill mentioned, I do plan to kind of expand these services to the family practice in future because not everyone has luxury of time. And so it was a modified, abbreviated kind of fit in what already was existing, added up onto that. So just wanted to share. Thanks for the inspiration, Dr. Osborne and everyone else.
Maybe I'll say something. Thank you so much, everyone. I also wanted to say something to Dr. Osborne because in Israel, we have a screening done for mainly for postpartum depression, but also for perinatal depression. It's done by nurses and it's added on to their job, and it's public health nurses that work mainly with infants. And a large thing what they were saying is that they don't feel prepared enough with their knowledge. And from that also, if you don't have enough knowledge, then your attitudes are, okay, should I screen, shouldn't I screen? And what happens if I use the EPDS and someone scores positive on question number 10, and so on and so forth. So there isn't, in Israel, we don't have a specific curriculum, at least, for the nurses that do that. They do have, here and there, like an hour of talking about these things, but I think doing a specialized curriculum they once had, now they don't have, could be something very important to do. Thank you.
This is Joy Burkhardt. I'm based in the United States and just wanted to say thank you for organizing the SIG. And also, one of the things we're really trying to work on here in the US, and I think some of this is relevant internationally, appreciate, learning from all of you, is sustainability of these programs so that we're training, and I'm thinking more about the clinical interventions or preventive interventions to bill for the services. So who do we train that's already billing? So there are sort of program models, and Elizabeth, I see you shaking your head. I think we connected before on this too. And so I just wanted to put it out there that we're well positioned to help think through some of this so that these evidence-based programs can be scaled in the current health delivery system. So I'd love to connect again, Elizabeth, and I missed the first presentation. I'm sorry. Hope to connect with you as well. Thank you.
Yeah, that would be great. It's very important, right? If you can't bill for the service, it's impossible to keep the service going. But we've actually been able to, it's offered as one of the treatments within our clinical service now. So we get, of course, like most women's mental health services, so many referrals every week. I mean, we just hiring people for it. Lauren, I know you feel my pain.
I sure do.
you could, I mean, we've hired, I think in the past, like 2 years, like 10 more providers and still everyone's full. It's just in a sort of a bottomless pit of need. And what's been great about a brief intervention like PrEP and to have all our providers be able to offer it is that because it's brief, not everybody needs to be seen for 6 months. And so to get someone in this low, kind of low touch intervention and be able to bill for it is really helpful because one, people are getting something and it's helpful to them and it helps them avoid more serious pathology down the line. But in addition to that, it really, you're screening people. So, wow, this person is really not doing well and this is not enough for them. So now we can switch it into high gear and get them more, weekly care. We can get them a medication consultation, like we can provide that. But because we have eyes on them through this program, I think it really improves the quality of care, but also that you can give it, they're not sitting on a waiting list for 6 months. And by that time, so many things have happened that are problematic, right? Not just for themselves, but for the family and for the baby.
Mhm.
But yes, I'm interested in all kinds of ways to make that even, more available and get insurance companies excited about things like this.
Yeah.
We're on the cusp.
I will, oh, sorry.
Go ahead.
Yes, Ellen.
I'm Ellen Polishuk. I'll just throw out related to that. I am working with Karen Zlotnick on a trial for ROSE, which is another postpartum depression prevention intervention. And we've developed an app and we're comparing it to delivering the intervention as usual. And I don't think any of us think an app is the same thing as an in-person intervention, but if people can actually use it and it's sufficient, it might expand the continuum of resources that we have. So I think there's a lot of creativity to be used still in thinking about how do we expand the ways in which we make care available and interventions available to people who might benefit.
Thank you. Yes, Deb. I think Deb wants to say something.
Thank you. I just wanted to add that I'm delightful to see the movement that's been going on in terms of developing a psychiatric fellowship. There isn't anything corresponding to that in terms of psychology internships, predoctoral and postdoctoral fellowships within a reproductive health specialty practice. And so those of us that are developing that type of curriculum, which is voluntary, there are just so few mental health professionals that are getting training, required training, or even optional training within their training curricula and internships. Certainly Postpartum Support International and the PMH certification, perinatal mental health certification, is fabulous. But there isn't any universal approach to that, nor am I aware of positions in some of the centers in which you work that are particularly recruiting mental health professionals as part of your multidisciplinary team. So I'm not aware. I'm interested to hear if any of you already have those positions or anyone aware of processes in developing those positions, fellowships, and postdoctoral placements. Thank you.
I think it's tricky. I think Liz does have psychologists and other non-physician mental health professionals in her program, so she can speak to that. I will say it's tricky billing wise. Like I have a program that's very much stepped care where we screen everybody, and we have social workers who are doing the bulk of the screening and brief intervention. We do have one psychologist and one NP, but we can afford probably to add a lot more social workers. We can't really afford to add more psychologists because they're more expensive and their billing doesn't keep up with it. So it's really tricky billing wise. But Liz can speak to that a bit too, I think.
Yeah, yes, although we have challenges just with trainees being able to bill with the format that we have. So that's more of our difficulty. But we do for non-PAR patients who don't have, we try to accept every insurance. There's a couple we don't. And for patients we get referred to, we're able, social work trainees working with either a psychologist or a licensed social worker are able to provide the care. But it's not like an internship program that's specifically focused on providing the care. And that really has to do more than anything with, billing and just the institutional structures that allow it to happen. But we try to provide different kinds of groups like this, salons and things like that through our service, just to give people exposure. And I have requests. There's so much interest, and it's unfortunate that our institutions aren't really, they don't make it easy for us to make those a reality.
Okay,
For
so
lots of reasons.
yeah, we have to end, but I want to thank everyone. First of all, I want to thank our speakers, Vered, Maya, Elizabeth, and Lauren, for your wonderful talks. Very inspiring, very interesting. I think everybody enjoyed them very much. And thank you everyone for participating and for the discussion and the questions that you raised. And I think this is something, to continue a discussion. We're starting now, and we could always continue in other meetings, in the main meeting or whatever. So again, thank you everyone for participating. And I'll say good night, good morning, good afternoon to everyone, wherever you are. Thank you.
Thank you.
Thank you.
you.
Thank you, Lena.
Bye.
Thank you.
Thank you.
Nice to see
Bye-bye.
everybody. Bye-bye.
Shalom.